should begin. I'm Dr. David Krause. I'm the Chief Medical Officer of Genomind. Thank you for coming to Genomind Grand Rounds. We're very fortunate and privileged to have Dr. Faith Gunning with us today. Dr. Gunning is an Associate Professor of Psychology in the Department of Psychiatry at Weill Cornell Medical Center. And specifically, she's the George Alexopoulos Director of the Weill Cornell Institute of Geriatric Psychiatry. Dr. Gunning has had a long interest in geriatric psychiatry, the aging brain, and particularly in biomarkers and imaging of the aging brain. And the way this conversation started was that Faith and I were talking about the difficulty in discriminating differences in or causes of cognition in older individuals. Dr. Gunning is a prolific author, and in fact, her output has increased asymptotically over the last several years. She's the holder of several NIH grants, and we are indeed very fortunate to have Dr. Gunning with us today. So we'll have a presentation by Dr. Gunning, then we'll have a Q&A, which will be moderated via the chat room. So you can forward questions via chat at any time during the or via Q&A at any time during the presentation, and I will moderate them at the end. Okay, thank you, Dr. Gunning.
Thank you for that very kind introduction and for inviting me here today, Dr. Krause. So before I get started, I'm going to tell you a bit more about my background to give the context of the presentation, and I'll go through. So I'm trained as a clinical neuropsychologist, and I also with a background in cognitive neuroscience. And I've combined my interests in these areas specifically based on early observations very early in my career and at the end of my training about the presentation of cognitive and mood and other behavioral symptoms in older adults with depression. It was one of the main groups that I was working with very early in my career during my clinical work. And I also have a longstanding interest and background since graduate school in rehabilitation medicine. So you'll see that throughout this presentation. And just to be at the outset, that the overall goals of my program of research and my group's program of research is really focused in two areas. It's to identify biomarkers or brain-based markers that can help us understand who's not responding to our available interventions so we can improve what we offer to them or figure out how to offer them something different earlier. And also more recently, I would say in the last several years, a lot of our work has focused on scalable interventions. It's hard to work with Medicare patients on a regular basis in New York and not notice how difficult it is for them to access many of them to access mental health care. So my work is primarily funded by NIH and also by private donors. One digital platform that I'm going to talk about, it was developed by Achille Interactive. I don't receive funds from them, but I do receive logistical support, technical support for that work. And I also have an unrelated study that not on depression that is an investigator-initiated study with them. So very briefly, as far as our thinking about depression and mood and cognition, you know, when I started off, we really thought of cognitive symptoms as being just a result of this depressed state in older adults. And this is where this question of, is this pseudo dementia, meaning the cognitive results of a very depressed state, or is this an actual biologic dementia that's where, that's where the field was at that time. And I still think that question exists. What we do know now, though, is that cognitive symptoms are really at the crux of probably representing the pathophysiology of depression in older adults. That cognitive symptoms, especially ones related to the cognitive control network, the cognitive control network really plays a key role in executive abilities, or the ability to multitask and plan and regulate one's affective response. That these are really, if there's difficulty in the functioning of this network, that we often see more complicated cases, and that this is core to the illness, not a result of necessarily the current depressed state, or although cognitive symptoms certainly worsen and are present during the depressed state. We also, so this is one of the key brain networks I'm going to talk about. We also know that the interaction of the cognitive control network with other key networks plays an important role in both the presentation of depression, the recurrence of depression, and also with how people respond to antidepressant interventions. So I'm going to touch upon the, mostly, I'm going to start with the cognitive control network. I'll talk a bit about some of our work on the salience network, and less so about the default mode network, although it also plays a key role in the presentation of how cognition changes with age, both in a positive and negative way, and also how depression presents as people get older. And finally, before I move on, I'm not going to focus as much on frank dementia. We do know that, again, going back to, is this dementia or a pseudo-dementia, that this is a dichotomy that doesn't really make sense. We do know that repeated depression, along, the length of untreated depression major depression does put people at risk for subsequently developing a dementia. In addition, and that there's some shared pathophysiology there. In addition, we also, so that, well, that's the main point I want to make. And also that sometimes the initial symptoms of a depressive disorder may really be exhibiting the prodrome of a dementia. Most of what I'm going to show you is from people who we can't absolutely say there is no early dementia, but that were pretty well screened. So as I was talking about the cognitive control network, I became interested in this network really early on when I was studying the aging of brain across the adult lifespan using MRI and cognitive assessment. And I started doing this in the 90s. So the cognitive assessment has changed, not that much, but the MRI techniques, of course, have taken off since then. But I became particularly interested in this network, and it's depicted here in yellow, including a large part of the dorsolateral prefrontal cortex, the dorsal anterior cingulate cortex, aspects of the posterior parietal regions. I became particularly interested in this because what we and others observed early on is that this is a network that is quite susceptible to normal aging. There's a great deal of variability between people, though. And also what we and others have observed, they started these studies at Cornell in the late 90s, and it was the Cornell group before I joined them was one of the first to really discover this as being a really important network in depression, is that we know now from multiple methodologies, EEG, MRI, cognitive assessment, clinical observation, that the cognitive control network is disrupted quite often in individuals who suffer from depression later in life. So for example, 40% of older adults in clinical samples who suffer from major depression also have executive dysfunction, which is really the cognitive expression of a disrupted cognitive control network functioning. And that the presence of executive dysfunction across groups, but within late life depression, is strongly tied to daily functioning, poorer daily functioning and disability. In addition, that disruption in the cognitive control network appears to predispose individuals to recurrent depression. So I already stressed how important this network is. Some other information to keep in mind is that during periods of acute and prolonged and chronic stress, that this network becomes less efficient. This network is also disrupted across a number of psychiatric and neurologic conditions that are not specific to depression. We know that we've shown, and others have shown, that poor or lower connectivity among the cognitive control network regions, that when the brain's at rest, is associated with poorer executive abilities, and that poor executive abilities, the presence of those during the depressive episode are also linked to poor response to traditional antidepressant medications, including SNRI and some of the SSRIs, citalopram, escitalopram, specifically. So this is a group that I became more interested in because I wanted to figure out, and the group wanted to figure out, how we could better treat these individuals who weren't responding well and tended to remain depressed despite an adequate dose of an SSRI. So this was historical data using some older MRI techniques. Some of our more recent data also demonstrates looking at white matter disease, using some fairly sophisticated approaches, that disruption in the cognitive control network, specifically the dorsal anterior cingulate, is associated with poorer set shifting abilities, or the ability to attend to alternate one's attention, which is very important for all of our daily functioning. In addition, in that same sample, we demonstrated that using a newer resting state connectivity analysis technique, that disruption within the dorsal anterior cingulate cortex and the connectivity within that region at rest was associated both with poorer set shifting and also poorer attention and working memory. We also have demonstrated in multiple studies, some of them predate me, but this one we conducted at Cornell and used hierarchical regression to group people by their clinical symptoms and cognitive profiles. And what we found, what you can see here, this is the group that had executive dysfunction. This group, the blue group, had some difficulty with responding to rewards. And this group was essentially looked like normal or healthy controls, non-psychiatric controls, age-matched controls. And this group, you can see they did not, they had a very poor response to antidepressant medication. So what we focused on from there was really testing out how we could target this network dysfunction. And because I'm a psychologist and a neuropsychologist, we ended up focusing on non-pharmacologic approaches. I think I'm a full proponent of pharmacologic approaches, and these tended to be individuals who weren't responding. So we identified a cognitive control treatment target. And this is based on work done in aging. that shows that across the lifespan, when individuals are asked to perform more than one task at a time, their performance decreases significantly. And this is cross-sectional, and this is a cross-sectional study. It's looking at people at different stages of development. My colleagues targeted this using what is now we would call a therapeutic video game. But at that time, it was a task, really, it was done in the laboratory at UCSF. And it was administered every day. People engaged with this task every day for 5 days a week for 4 weeks. And it was basically, essentially, it's like what you would see in more video games where they combine like a motor type driving task where you have to steer while also looking for targets, and it becomes increasingly more difficult. So this was a desktop version of it. And what they found essentially is that they were able to train adults in their with this 4 weeks of this training, adults who received the multitask training, older adults who received this multitask training, 1 month after the training, they showed very little cost from the cognitive training, when asked to do executive tasks and multitask, and that these gains appeared to persist 6 months later. So this was intriguing, and this was done it was a small pilot study of healthy aging and looked at extreme adult age groups. So this was interesting enough that we collaborated and designed a study where we compared this, an updated version of this intervention, a gamified version of this intervention that was delivered over the iPad, to the gold standard psychotherapy for older adults with executive dysfunction. And I will say, when I joined this work, the group asked me multiple times if I wanted to engage in this study and work on this study. And I didn't think it was going to work, given my long clinical history in rehab medicine. I thought, why would this, things don't transfer when you train people to do new tasks using these repeated training tasks. They tend not to transfer to other skills. So I don't see how this is going to improve cognition or mood. But I was at the stage in my career where I had difficulty saying no. I think I said no 3 times, and then they convinced me, and I really agreed to be part of this study because they were collecting MRI data, and the control condition was a psychotherapy condition. And I was interested in that data. So, so much to my surprise, what we found in that initial proof of concept study is that when older adults with depression, and these were people, this group happened to be, they were primarily medication free. But older adults with depression, if they were randomized either to the gold standard psychotherapy for depressed individuals with executive dysfunction called problem-solving therapy, in red, or to Project Evo, which is the multitasking video game training, cognitive training, at 4 weeks, there was no difference between the two groups. They showed equivalent improvement in mood symptoms. And even though the video game actually ended at 4 weeks and they continued the psychotherapy through 8 weeks, at the end of treatment, the intervention, there was no difference. And interestingly also is that only the therapeutic video game intervention group showed an improvement in their cognitive abilities, including attention and like sort of sustained attention and more complex or dual tasking type attention. So then I was convinced enough to really dive into this work, head first with the group. Because I've been working with individuals, patients who were suffering both from mood symptoms and cognitive symptoms. And often what we see in the literature and what I saw clinically is that even when the mood symptoms did improve, often the cognitive symptoms remained and were disruptive to daily functioning. So we followed this up with an NIH study, first looking at the brain mechanisms. And what we did is we looked at functional connectivity in the cognitive control network, pre and post. And this was the first phase of this study. It's an experimental therapeutic study. And the first phase of the study by design was looking at target engagement. So it was a single group. Everybody got 4 weeks of this Project Evo video game. And what we saw was an improvement in connectivity and functional connectivity at rest from baseline to week 4 or end of the therapeutic video game. And this was associated with an improvement in both executive abilities and an improvement in mood symptoms. So we then have taken the next step of this work and recently finished the RCT phase of this study where we compared the Project Evo or the cognitive control intervention to a same intensity, same duration matched video iPad delivered video game that is not meant to target the cognitive control network. And we're in the midst of analyzing those data now to see if the results hold up against a very strong control and if we can replicate the mechanistic change. In addition, so I'll just show you from the single arm, again, limited by the fact that, this could be placebo, this could be other factors coming into play. So we really need to replicate this in a larger sample in the RCT phase. In addition to this study, we're also applying this to other medical populations. So we just launched a study in older individuals with depression following stroke and who have both depression and cognitive impairment to see if this can augment their daily functioning while also improving cognition. We're also extending this work to a newer iteration where we just completed a RCT, fully remote RCT of post-COVID cognitive dysfunction, and those results will be should follow soon. We're at doing the follow-up assessments. So while conducting these trials, we're also looking at in separate samples, we're also looking at other brain-based possible markers that can help us understand who isn't going to respond and to understand that early. So as you all probably know, small vessel disease or cerebrovascular disease is quite common as people get older and is easily observable on MRI. It also tends to be more common in older adults with depression, also in dementia. So there's a vascular component to Alzheimer's dementia that we didn't recognize years ago, but it also tends to be this white matter disease is also associated with poor outcomes of depression in older adults. So we've been looking at a newer way of looking at this to see if we can identify the correlations between these white matter changes, like these white matter hyperintensities and macroscopic white matter hyperintensities you can see. And it's it's a robust finding from the standpoint that we see it over and over again in different populations. So it's certainly significant. The correlations with behavior, both mood and cognition, tend to be fairly weak, so not a great marker. So we're always searching for something that we can use at the more individualized and automated level to be a good marker to help us understand how to move forward, how to identify people who aren't going to respond to our interventions so we can offer them an alternative. So we did a study where we used this technique called peak width of skeletonized mean diffusivity that's been shown to be quite sensitive to cerebrovascular pathology. And this has been shown beginning in 2016, but this has been shown across multiple clinical samples as being a clinically useful indicator of small vessel disease or vascular disease in the brain. And so we did a study where we looked at the relationship of this to cognition in older adults who are suffering from depression, and also in non-depressed older adults, to see if this may be a good marker of individuals who may have poor outcomes of their illness. And we saw a strong relationship. Well, both groups showed a relationship with processing speed, but the relationship between this indicator of white matter disease or cerebrovascular disease was much stronger when you than in controls when you look at things like delayed recall, which is really important in aging-related diseases, and also with various executive functions. We did a direct comparison. We did some modeling where we compared this newer measure of white matter disease with our traditional measures, multiple metrics, white matter hyperintensities, other measures of microstructure that have typically been used, and found that the predictive value of this was significantly greater than our conventional markers. So we're now applying this to some of that, working to apply this to some of the ADNI or publicly available data sets so we can analyze these relationships and see whether this may be a useful marker in larger samples of older adults with both cognitive and with or without mood symptoms. The beauty of this is it's publicly available and fully automated. And this is something that this is a method that has been advanced by the MARC VCID consortium focused on vascular dementia. So what we do know is I've talked about primarily this one subtype of depression. We call it depression with executive dysfunction. And again, as I said, about 40% of older adults with major depression also have executive dysfunction and this disruption in the cognitive control network, both during the disease state or the illness state, but also during remission. But we know that this is not the only pathway to depression in older adults, and we have focused on other clinical subtypes that tend to be difficult to treat. So we've over the last few years, we've turned our attention to apathy, which is a really important clinical syndrome in aging, both in psychiatric illnesses and in dementia. And of course, one of the reasons it's so important is that it's quite disruptive to daily functioning. It interferes with daily activities, engaging socially, necessary activities like bill paying, attending medical visits. It's also in depressed older adults, it's the frequency or the prevalence is about 45%, whereas in healthy older adults, it's about 5%. And the treatments that are available, there are some pharmacologic interventions that have some success in treating some individuals with apathy. The behavioral interventions are quite limited and haven't shown great success. So similar to what we did with this depression with executive dysfunction, we analyzed some of our MRI data we analyzed cognitive data and we analyzed MRI data looking at some of the networks that appear to be implicated in individuals who have both depression and apathy in later life. And what we really honed in on was this salience network, which is really important for telling us what information is important and what's not. And in apathy, in major depression, so what we, as you all probably know, what we tend to see in major depression is individuals who will, with neutral information, they often will view it negatively. Or even positive information may be viewed negatively. In apathy, there does appear to be a disruption in this salience network where the ability to just have assign something importance, either internal or environmental information importance, appears to be disruptive, which may contribute to this motivational disturbance that prevails in individuals who are suffering from significant apathy. And what we demonstrated recently is a disruption in this salience network in older adults who have apathy and depression relative to older adults with depression alone. There's disruption in the connectivity in the dorsal anterior cingulate and also in the insula and aspects of the temporal cortex. And these disruptions in the resting state connectivity in the salience network are associated. So we examine these at baseline prior to the start of a 12-week course of escitalopram. And what we found is that individuals with these connectivity disruptions were less likely to remit and also had more persistent cognitive difficulties, particularly executive dysfunction. So we did go back and do a post-hoc analysis of apathy results that we had from that Project EVO study using the therapeutic video game, and found a modest relationship between connectivity within this network and apathy following intervention. Our next steps are, so while I'm a proponent of this cognitive intervention that I already presented to you, not because of any tie to the company, but because it's actually, I haven't seen that many cognitive interventions that appear to work that well and to transfer to other skills. And also it's quite engaging. And I think the gamification part of it is really important because we don't have dropouts. People finish it, we monitor their use remotely, and they use it and they like it, which is often quite a problem with our interventions, but definitely with our remote interventions. People tend to drop out quite early if they don't like it. But for apathy, we're just launching a mechanistic RCT right now that's focused on apathy in older adults with depression, and this is their starting place. We will extend this work to more traditional diagnoses of MCI and likely early dementia. But we used a publicly available platform for this because we really wanted to, and the PI of this study really wanted to target specific functions that based on the literature and our own results, we thought, and our model of apathy, we thought would be important to improve the syndrome. So we'll see. We're just starting the randomization, randomizing people now. We did design the study. We thought about this a lot, and we ended up designing the study with people who had individuals who can help them comply with the intervention, because it does require, or we do want daily use for approximately 20 minutes a day. So more to be revealed from this, but this is our first step as far as trying a cognitive intervention in apathetic individuals or individuals suffering from apathy. And then finally, I'm going to shift to a little bit of our psychotherapy work. And this work was really started by George Alexopoulos and Pat Arian, who was at UCSF when they started it, and is now at University of Washington. And they created an intervention. So one other really key aspect of depression, and this is across the lifespan, not specific to older adults, is, as we know, a key feature of major depression, people either have to have sad mood or be anhedonic, or have like blunted engagement in response to what is typically rewarding. So this psychotherapy was really designed to target individuals who are experiencing difficulty with enjoyment in life during their depressive episode. And so we know that there is a reward system dysfunction in major depression, and that's associated with anhedonia. The intervention is really a simplified behavioral activation type psychotherapy. So it really focuses on, it's designed so it can be delivered in the community, and community therapists can be trained to, it's manualized, they can be, community therapists can be trained to deliver the intervention. One, I mentioned wanting, moving toward more scalable interventions. We had some great psychotherapies that we tested out at Cornell, and they're still quite effective. But what we found is that they weren't making it into the community. So this one is really designed to be in the community. And what, when comparing, this was the main efficacy trial that was published about a year or so ago. And what you can see from the curve is that there's no difference between improvement in depression in this engage or reward-based behavioral activation, streamlined psychotherapy versus a more complex problem-solving therapy that is CBT focused, also a very active intervention, but more cognitively focused. And the importance here again is that the engaged therapy is more scalable. And we have started to, and others have had to scale this into community settings. But we want to know from a psychotherapy standpoint, again, who's responding, who's not responding, and because if people aren't going to respond, we want an early marker that they're not going to respond. We don't necessarily, it's not ideal from a clinical standpoint to wait till an 8-week, 12-week mark if we can help it. One of our junior faculty did an analysis of all of our psychotherapy data from 20 years of psychotherapy trials, and took a machine learning approach where they identified individuals who would respond early on in psychotherapy versus those who didn't, and looked at an array of predictors, severity, demographic factors, cognitive factors. The clearly strongest predictor of early risk of persistent depression in older adults is low perceived social support. So we had a measure of social support in that archive of data throughout all those years. And so this is really, the importance of social support and the detrimental impact of social isolation has really been in the media front and center since COVID. We have a very talented junior investigator, Neely Salmanoff, who's been investigating. She identified this as the strongest predictor of early poor response to psychotherapy, and she basically modified Engage after doing some. I'm going to sort of move through this more quickly, so we have time for question and answer. But what she did is she modified the Engage psychotherapy that's really focused on having people engage in rewarding activities. And in her analyses, when she looked at these data sets that had this Engage psychotherapy in it, what she found is that it really was the social engagement in social activities and rewarding social activities that seemed to be driving improvement, like in activity levels and everyday behavior, and also the decrease in depression. So she took this simplified community ready intervention, or what we consider to be community ready intervention, and she modified it so it's really focused on the social aspect of behavioral activation and the social aspect of engaging in daily life and increasing rewarding social experiences. And that is the focus of this psychotherapy that she's testing. And she's called it Engage and Connect. She's looked at early reward mechanisms to see if at the brain level, to see if they may predict, but these results are preliminary. The brain results are quite preliminary at this point. So she is currently examining both the efficacy of this Engage and Connect intervention, and then using more advanced MRI approaches that really allow us to optimize the signal we're getting from fMRI and look at the individual brain over time, including in these structures that are really important to reward in depression, like the subcortical structures and the nucleus accumbens. And so far, she's showing that in collaboration with others at Cornell, that we can get a really good signal over time that appears to be related to improvement with her intervention, but it's and reduced depression severity. But it's early days. This was a pilot study, and she's incorporating some really important advances in MRI that other folks at Cornell have really driven, and we're applying in our data sets as well, including optimizing the sequences that are used so we can get it networks at the individual level, not only at the group level, and we can get good quality over the course of interventions, not pre-post, but more frequent time points. And also looking at the organization of the brain. We're able to look at the organization of the brain at an individual level. We're used to averaging all these regions together and looking at an average map, but we're really working toward an individualized approach, because for a brain marker any marker to be useful from a treatment prediction standpoint, we really need to be able to apply it at the individual level. And then I'm going to wrap up, because I'm running long, with some next steps. We are continuing with these digital cognitive interventions, and also applying some skills-based interventions that are more, I would say they're psychotherapy skill-based digital interventions that we've created and now modified to be tailored for older adults with anxiety and depression. And we're also working at that, when I'm talking about using MRI as a predictive biomarker for depression. This work we're actually starting, not in older adults, but we're conducting a pivotal trial right now and working with the FDA and the NIH, where one of my colleagues, Connor Liston, he and I are co-PIs on this, and he developed a way of really mapping, of potentially identifying a biomarker that can help us to guide where we stimulate the brain in using transcranial magnetic stimulation. And the preliminary efficacy data looked quite strong. If you assign people based on their connectivity patterns to one of two different stimulation sites, the efficacy looks much higher. But we're doing the confirmatory efficacy trial now, with the goal being that this, if it works, that we would work to roll this out into practice. And with that, I want to stop and thank you. And I want to just thank all my, it takes a village to do these kind of studies. And I just want to thank my primary collaborators on the work that I presented.
Wow, thank you, Faith. I'll invite the audience to pose any questions in the Q&A box below your screen. So one thing you said, Faith, and a lot of this is unfamiliar to me, but one thing you said is that MDD increases the risk of dementia. But is that Alzheimer's disease dementia?
So
have you measured, plaques and tangles and so forth?
So other people, it does appear, there's not a lot of, there's certainly not a lot of postmortem work. There is postmortem work, and it's not ours. But there is postmortem work to some small postmortem studies to suggest that it may be Alzheimer's type dementia, because what we used to think is that MDD may be related to vascular dementia, but not necessarily to Alzheimer's dementia. But it certainly appears to be related to Alzheimer's dementia. And it's not plaques and tangles. There are some other like blood-based biomarker studies that suggest that link, or PET studies that suggest that link. So yeah, the link, the link certainly appears to be there. I don't think it's as strong as sometimes when the media gets a hold of things, or it often appears like the relationship is stronger than it is. So I think the message that all older adults are going to end up with a dementia is clearly not accurate, or that the majority will, but it certainly does increase the risk. And there is some data to suggest that repeated depressive episodes, untreated or treated but not successfully, increase the risk of dementias.
It's a little bit of the chicken and the egg, isn't it?
Yes. Yep. Yes, it definitely is. And I think it still is. So we have been in this place for a while, that as far as the causality, I think that still remains a challenge.
For your Project Evo,
yeah,
how does that increase connectivity? What's the mechanism of action?
So what we think is that, and if you had told me this 10 years ago, I would have said you were wrong. But it's daily, it's essentially, I think of it as a sort of a neuromodulation approach, a very non-invasive neuromodulation approach that through repeated activity, that the brain is actually changing. through the repeated activity. And that is what, or may be changing. And that may be what we're seeing on MRI. I will say I'll be more comfortable with those findings once we look at it in relation to the very active and strong control, because in that study, we can't really separate out the impact of improved depression. Not yet, but there are animal studies to suggest that these kind of paradigms also may, they're both animal and human studies. I think there is a role for neuroplasticity in that improvement or change. But
I was going to say, we know from other types of data that neuroplastic changes can happen in the brain incredibly quickly, much more quickly
Right.
than we would have anticipated. For example, from psychedelics and ketamine and so forth, that these things can happen in a day or days even. I thought it was interesting that the word connection came up. This is apropos of nothing. The word connection came up in two different contexts. One is
Right.
neuroanatomic and the other is social. That was just something I observed. How do you measure, what is the tool that you use to measure executive dysfunction?
So we use multiple measures. We have, I'm hesitating because they're so imperfect. But we use the Stroop, which is essentially a cognitive interference task. And we also use this traditional task, the trails. So really where you're alternating attention between two different numbers and letters. We also have used computerized tasks. Like one of the tasks that we used, the problem with some of the computerized tasks, even though our traditional tasks are, they don't give as fine-grained a measure, some of the computerized tasks aren't as reliable. But the computerized tasks we've used are really based on tasks that have traditionally been used in the ADHD literature to look at sustained attention. And in our newer studies, I think like many people, one of our studies, we went to a fully remote cognitive battery that's been validated, not by us, by an external group that's been fantastic because it's computerized all these different aspects of executive functions that we're interested in. We also ask people about their daily functioning. Like we often find that self-reported executive problems don't line up well with objective measures of cognition. I don't necessarily think it's because people just aren't good reporters of, I think it's possible they may be capturing different aspects of executive functions.
So what are for a clinician on the front lines, if they wanted to evaluate executive function, what are the
I would give this, honestly, I would give this Stroop. It's like 80 years old, and I would give this Stroop. That's what we actually in our hospital, when George was there and overseeing many of the psychiatrists, they gave it on the units. And our geriatric units, they would administer it as part of their assessments. But it takes about 3 minutes. So it's not time consuming.
And so if you had an older adult with symptoms of executive dysfunction and depression, compared to an older adult with depression, but without symptoms of executive dysfunction, would your treatment differ?
So mine would, from the standpoint I still think if first line antidepressant medication, if the person was not on it, I would still, given that many of them have minimal side effects, I would still, if they could, I would still recommend they consult a psychiatrist about that. But I would, if it were a patient of mine, I would try to also augment, if I could, I would try to augment the treatment with one of these cognitive interventions. And the problem with these cognitive interventions is that they are not covered by insurance yet. So one of them is actually available. I don't know if I'm allowed to talk about this. I'll just say it. One of them has been FDA cleared for ADHD. So it's off label.
What is that?
It's called Endeavor RX, but it's the one that, like the video game that I showed, it's a newer iteration of it. Now they're spamming me with the company is to prescribe it to my patients, but I actually would use it. Some of our clinicians try to prescribe it to their patients. It's just they have to have the means to pay for it, which it's not like paying for TMS. It's also not as powerful, but.
Right. All right, well, it's 12:59, so I think we've come to the end of our presentation. Really want to thank you, Faith, for engaging and interesting presentation. And I hope we will continue to interact in other forums.
Great. Thank you so much.
Thank you.
Thank you for inviting me. Thank you for the questions.
It was a pleasure. Thank you.